Deceptive Diagnoses and Catch-22, which I put together with Dr. Scott. So I have no disclosures. And I would just like to start with a case. So as I'm going through this case, I'd like you to think about your differential diagnosis in particular, as well as maybe where you would start with managing this patient. So this is a 27-year-old female coming from Owen Sound, and she's being transferred to London to see the OBGYN team. She was previously healthy. She just had her first pregnancy and an uncomplicated spontaneous vaginal delivery 5 days ago. And then she experienced about 4 days of growing pain and some difficulty ambulating. On postpartum day 4, so essentially yesterday, she developed some shortness of breath, blood pressure of 100/60, and was a bit tachycardic with a heart rate of 125. Then today, on postpartum day 5, she became hypotensive, hypoxic, and developed new atrial fibrillation. On a bedside echo, which was done in Owen Sound, they found that she had globally decreased left ventricular function. So paramedics were called to transfer this patient to London for further management. And when they arrived, they had a blood pressure of 76/51. The patient was now in sinus rhythm, but still tachycardic at 120, and had an O2 sat of 96% on a non. That's fair enough. I don't have an explanation for that. I was not. Yeah.
What are your options? I mean, if they're not comfortable, well, I mean, it depends on the comfort level. I mean, the way this story was sold was that she had, they described it as a severe postpartum cardiomyopathy, which they felt completely inadequate to manage, and so they wanted her transferred. We didn't get involved until we found out she was on the doorstep. So you can argue with the decision all you want. Somebody accepted the patient, and she's about to show up. So, I mean, rerouting them and saying, go back home and think again about what you've got is probably not going to work.
Well, like I said, you got the intention that you got. I mean, does this seem like, I'm surprised OB-GYN accepted this. This doesn't seem like OB-GYN.
Well, I think it was initially when the call was made, if we go back a slide, at the time the call was made, one more back, blood pressure wasn't terrible, a little bit of high heart rate, globally reduced systolic function. At that point, it was described as a postpartum cardiomyopathy. Well, they come to OB-GYN, yeah. Because do you think cardiology is going to accept somebody who just delivered a baby? You can't get them to accept MIs. Come on.
All right, I'm going to cut you guys off. I'm glad you're already engaged. This is good, but we're going to have a long talk if it goes too much this way. So residents, you've got definitely what was on the differential from the transferring physician. So postpartum cardiomyopathy is a big concern. Is there anything else you're thinking with this presentation and the new information that's developed in the last 15 minutes? Absolutely. So eclampsia, PE, yeah. Absolutely. So I think those are all really great. So I'm just leaving this really broad. So you're thinking neurologic things, you're thinking cardiopulmonary, infectious, metabolic, vascular, or specific pregnancy-related things. So mention things like eclampsia, which is excellent. So keeping things really broad. Patients now in your emergency department, their vital signs are even worse. So now you can't obtain a SAT, so obviously perfusing pretty poorly.
their blood pressure is only palpable, can't get one on the machine, and they are now febrile and have a low glucose. They're also profoundly rigid. And this is their blood work. So it was already mentioned, and for the sake of time, I just want to point out a few things here that make me a bit more concerned for eclampsia or HELP syndrome. So we have low platelets, we have liver enzymes that are on the rise, we also have profound rigidity, which makes me wonder about whether they have clonus and other things like that that might present with eclampsia. So the topic for today is essentially going to be late pregnancy and postpartum complications. So the two things that I really want to discuss are eclampsia and pulmonary embolisms. So for eclampsia, I would like you to be able to describe the epidemiology, pathophysiology, and management of eclampsia by the end of the day. And then for pulmonary emboli, outline your approach to a PE in this specific population, understand the role of risk stratification tools and D-dimers for these people, as well as be able to compare and contrast the risks and benefits of VQs and CT scans in the postpartum and pregnant population. So what is preeclampsia? Preeclampsia is a presentation that can occur anywhere between 20 weeks gestation to 4 weeks postpartum, and it's new onset hypertension in a patient who was previously normotensive. And they usually should have this presentation on 2 occasions, and the hypertension is a blood pressure of 140/90. These patients often usually have proteinuria as well. You can have more severe preeclampsia, which is a higher blood pressure, so 160/110, and these patients also present with other symptoms. So they can have visual disturbances, headaches, altered mental status. They can also develop symptoms that go along with HELP syndrome, so things like right upper quadrant pain or epigastric pain. They get transaminase elevation, decreased platelets, and ultimately renal insufficiency and pulmonary edema. So then what's eclampsia? Eclampsia is when these patients who have preeclamptic symptoms then develop generalized tonic-clonic seizures. And this occurs in about 1.5 to 10 pregnancies in 10,000. So it's not super common. And when does it happen? Most of the time, or 50% of the time, this happens in women preterm, so before 37 weeks. It can happen during delivery, so intrapartum, and then there's a good portion that happen postpartum as well. And it's that postpartum population that I'd really like to talk about because that's the one that makes me a little bit antsy as an emerge doc, because these patients come in no longer looking pregnant. You may not know that they're postpartum, and these are the ones that we actually might be more likely to see because they're no longer going and presenting to OB triage as their first line for care. So about 50% of eclamptic seizures occur in the postpartum period. 90% of those are within the first week. So usually you're in this safe zone where they're still clearly a postpartum patient, but there is a 10% of that group that present later and can catch us off guard essentially in the emergency department. And so those ones that present beyond 48 hours are considered late eclampsia, and the typical definition is up to 4 weeks, but there are case reports up to 8 weeks postpartum, so something to keep in mind when you're thinking about it. So how does this happen? How does eclampsia and preeclampsia happen? During pregnancy, your placenta is supposed to connect to the uterus and the myometria via these spiral arteries. In eclampsia or preeclampsia, those arteries don't form properly. There's a problem with angiogenesis, and that ultimately leads to a bunch of pro-inflammatory proteins and anti-angiogenic proteins being systemically distributed. That distribution of pro-inflammatory markers then leads to vasoconstriction, and then with the systemic vasoconstriction, you then get more endothelial damage. It becomes a bit of a vicious cycle, and ultimately patients present with proteinuria and hypertension as the initial symptoms. If this persists without blood pressure control and management of that persistent vasoconstriction, they can develop HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelets, and then they can ultimately develop eclampsia. And the thought behind the eclampsia is that it's essentially caused by cerebral edema secondary to vasoconstriction in the brain. So what symptoms might we expect in patients who are about to have seizures or are bordering on the more severe side of preeclampsia? Hypertension was already mentioned. Headache is very common, over 66%. Visual disturbances, right upper quadrant pain, and then the scary one, asymptomatic. So a lot of these patients may actually be asymptomatic, and the other scary part is that their vitals may look relatively normal, because if you think about the population that's getting pregnant, there tend to be young, previously healthy women. Normotension for them may be closer to 100, 110 systolic, so relatively they could be hypertensive with a blood pressure of 130, so not even quite meeting our definition. So they can look relatively asymptomatic, but could still be at risk, so a little bit frightening. And then some additional symptoms, ankle clonus and peripheral edema can be seen on exam as well. So what do we do for these patients who actually present in eclampsia, so having seizures quite unwell? There's 3 priorities in these patients. The first priority is to manage their seizures. Second is their hypertension, and the third is to maintain volume status. So for seizure management, this is very different from our normal seizure patient. We're not giving benzo as our first line. You actually want to load these patients with a huge amount of magnesium. So giving 4 to 6 grams of magnesium right off the bat, and then continuing an infusion of 1 to 2 grams per hour. So I know that's an amount of magnesium that makes me a little bit uncomfortable, because I can't say I've ever administered anything more than 2 grams at a time. But keep in mind, these patients do need a really big load. If they continue to be refractory, this is where you can fall back on your usual seizure management, so appropriate to try benzos, and to also then try things like phenytoin or our usual management if they remain refractory. Hypertension, you want to target less than 160 over 110, and hydralazine or labetalol, whatever your preference is, are both completely appropriate options. And then for volume status, you want to keep these patients well hydrated with good urine output, so insert a Foley and make sure they have urine output of about 1 to 2 milliliters per kilogram every hour. So now that we've chatted a bit about eclampsia, which is not something we deal with very often, I just want to jump back to our patient. So this patient arrived with multiple things on the differential, very, very sick. So the management that was offered to this patient or given was their hyperkalemia was appropriately treated with calcium, insulin, and glucose. Their seizures, again, appropriately treated with magnesium. So the doctors treating thought about eclampsia as a possibility and gave both magnesium and phenytoin. Their shock was treated with everything in the hospital. So epi, bicarb, phenylephrine, norepi, dopamine, every pressor you can think of was attempted. And 3 antibiotics and steroids were attempted for the possibility of septic shock. So really this patient had everything administered to them, but unfortunately she did ultimately end up passing away. The postmortem said that they believe the cause of death was probably invasive group A strep, which they thought was secondary to a tear, a second-degree tear that she had received during vaginal delivery. So although we spoke about this as a case of possible eclampsia, this was one where this is something I would definitely want to keep on my differential. But remember in pregnant patients that the normal things that apply to every other patient are still on the differential, as well as the weird and wonderful that we see in pregnancy. So these patients can be extremely difficult, extremely complex. And I just want to remind you of some of the more rare things that we don't think about that we need to keep in mind when treating these patients. So ultimately for eclampsia, before we move on, keep it in your differential. Any woman of childbearing age, especially if she's presenting with hypertension, headache, or seizures, these are women that may not always look pregnant because it can happen at 20 weeks, or they may actually be in the postpartum period where this can still occur. As mentioned, there's the risk zone, and again, these patients can be fairly asymptomatic and might have relative hypertension, so keep it in mind. It can be fairly insidious and sneak up on you. So I would now like to jump to another case before we discuss our next topic. So we will call this patient Natalie. This is a 29-year-old patient coming in for her second pregnancy. She has a healthy 2-year-old child at home, currently 36 and 4 weeks gestation. She is coming in with new onset shortness of breath, chest pain, states it's worse with deep inspiration. She has no fever and no cough, no real infectious symptoms. Her vitals are, as you see there, slightly tachycardic, normal blood pressure, a little bit tachypnic, normal O2 sats at 95%, and no fever. So, is there anything on your differential or anything you're thinking in terms of investigations at this point? Absolutely. Yeah. Anything else on your differential? A few things. Cardiomyopathy of pregnancy, I guess, but she's perfusing well. She doesn't seem to have any signs of hypoperfusion or cardiac shock at this point, but absolutely throw on the POCUS and see what her heart looks like. I think that's fair. I couldn't get out of this presentation without putting on a Rosen's list, of course. So this is a list for pleuritic chest pain, so things you might think about in any patient with pleuritic chest pain. And of course, pulmonary embolism is up there, and as you clearly guessed by the top differential, that is what we'll talk about here. So what investigations are you thinking about ordering in this patient if PE is the biggest thing that you want to rule out on your list? Yeah, leg Dopplers I think are reasonable. Yeah, ECG, chest x-ray, I would absolutely do my basics. Do you want to get any blood work? Yeah. So if there's a massive PE, we might get some right heart strain. Absolutely. So I put question marks here because this is very debatable, and that's what I want to go through today is what do we actually do in these patients and what does the evidence say we should do? So how often do thromboembolisms occur in pregnancy? In normal adults under the age of 40, so presumably the most comparable group to pregnant women, it's a rate of 1 in 10,000. In pregnancy and postpartum patients, that rate increases tenfold or more to about 1 to 2 per 1,000 patients. And of those thromboembolic events, most of those are DVTs, but 33% or a third of those are pulmonary emboli. So when does this occur? Does it occur in the first trimester, third trimester? So there's been several studies that have showed that the incidence is highest immediately postpartum, so usually in those first weeks postpartum, but the risk does increase as women progress through pregnancy. So first trimester is not too much of an increased risk, but it does progress. Third trimester, much increased, and then you can see that immediately after delivery there's a huge spike, and that's where about 50% of pregnancy-related thromboemboli occurs in those first 6 weeks postpartum. So how far after pregnancy do we have to worry about this? Again, many studies have showed that this risk actually levels off and becomes about baseline around 12 weeks postpartum. So the risk is still mildly elevated, but at 12 weeks, they can be considered baseline risk again. At 6 weeks postpartum, 1 to 6 weeks, again, I would still be very high alert in these patients for this. So what makes these women so susceptible? Well, we can think back to Virchow's triad of hypercoagulability, endothelial injury, and stasis, which together make people higher risk for thromboembolic events. So in pregnancy in particular, a lot of physiologic changes actually make these things worse. So from a hypercoagulable standpoint, they have decreased fibrinolysis, increased coagulation factors, and decreased anticoagulant factors. And that's for good reason. Obviously, during delivery, you don't want to have a postpartum hemorrhage, so the body prepares itself for that to help avoid any complications in delivery. In terms of endothelial injury, women with preeclampsia are at higher risk because they can have more endothelial injury. Also trauma during delivery, which is probably where that increased postpartum risk comes in, can predispose you. And then of course, there's issues with venous flow, so there's a big lump sitting on the IVC. This obviously creates compression on the IVC and pelvic vessel compression, which creates a perfect stasis environment. Other risk factors include multiple gestations, postpartum hemorrhage, postpartum infection, C-sections, or blood transfusions. So this is essentially the algorithm that we go through for our normal patients outside of pregnancy who are presenting with pleuritic chest pain and possible PE. We do a risk stratification score. People can choose their score. Sometimes we do Perk and Wells. Some will use Geneva. Can do a D-dimer, whether you believe in age-adjusted or not, I'll leave for another day. And then you can do imaging, so Dopplers, VQs, and CTPAs. But what's the problem with these things in pregnancy? Well, for one, your risk stratification scores aren't going to work as well. 75% of women in their third trimester complain of dyspnea, so they're all going to be short of breath. Heart rate naturally increases about 25%, so everyone's going to be up about 15 to 20 beats per minute from their baseline. And peripheral edema is common. So yes, it should be symmetrical, but it is going to be harder to interpret whether this edema is from a DVT versus normal edema in pregnancy. D-dimers elevate as we go through pregnancy, and I'll show you that in a little bit as well. But ultimately, as Danielle mentioned, we should be using a D-dimer in patients that we know are low risk already. If our risk stratification scores don't work, how do we know who's low risk? So again, that becomes a little bit dicey. And then from an imaging standpoint, the diagnostic capabilities of these tests actually change in pregnancy, and they aren't the same as in our typical population. So that's one issue. And then furthermore, there's our concern with radiation. So there's risk to maternal tissues, and particularly breast tissue, which is getting a huge amount of radiation with CT, and fetal radiation as well. So what do the guidelines tell us to do? So I looked at 5 different countries or continents, essentially. In Canada, they say there's no value for risk stratification, no value for D-dimers, and that you can do a CTPA or a VQ, but the VQ is preferred. So it doesn't really help guide you in terms of which imaging modality, and doesn't really give you any options for avoiding imaging. In the US, they say nothing about risk stratification scores in their guidelines. They say no to D-dimers, and they suggest doing a VQ if your chest x-ray is normal, and to do a CTPA if your chest x-ray is abnormal, and we'll discuss why that is a little bit later as well. Risk stratification scores in the US and in the UK, both out, and again, they suggest CTPA or VQ, and they prefer CTPA based on your chest x-ray results. And then interestingly, in the EU and Australia, they have similar guidelines. They suggest that there may be some value in a D-dimer if you get a negative value. And they also suggest doing Doppler ultrasounds of the legs as your first line, because if it's positive, you may be able to avoid radiation. And then following that up with a VQ or CTPA if needed, based on your x-ray results to make that choice. So what do the holy books say? Well, Danielle's already referred to Rosen's. And interestingly, the Tintinelli's chapter and Rosen's chapters on PEs are written by the same physician. His name is Dr. Jeffrey Klein. This is Dr. Klein. And this is his algorithm. So Dr. Klein is actually the gentleman who wrote, it was the first thing I found when I Googled him. I had to put it up. But he's the gentleman who wrote the Perk Score. So he actually has a lot of experience with PE, and I think his opinion is obviously quite valuable if he was asked to write all of these chapters. But I find his algorithm quite interesting when you compare it to the guidelines, because it's very different. So he suggests doing a Doppler ultrasound of the legs first, in hopes of avoiding any form of imaging or radiation if you get a positive result only. Then moving to a Perk Score, or your pretest probability, whether you feel that they're low, whether they are low risk. And then moving on to a trimester adjusted D-dimer. And so he suggests a different cutoff. It's cutoff of 750 in the first trimester rather than 500, 1,000 in second trimester, and 1,250 in the third trimester. And then if all of that comes back and you still need to do imaging, a VQ scan is suggested if you have a normal chest x-ray, and a CTPA if you have an abnormal chest x-ray. So I'm not going to dwell on these because you can look them up and we should all know them fairly well anyways. But this is the Perk Score. So essentially, if people are completely negative in all these things, you can rule out a PE and don't need to move any further. And then there's the Wells and Geneva scores, which help us put people into low-risk categories so we know who it's worth doing a D-dimer on and who we shouldn't bother and should move directly to imaging for. So in terms of risk stratification scores, who has looked at pregnancy and the use of these scores? Well, there's been very few studies done, unfortunately, and this is one of the most recent ones. This is a study in 2018, so this year, and it was done in Tunisia in a single center. This is a prospective study of pregnant and postpartum women who had suspected PEs, and they were already undergoing imaging, so either a VQ or a CTPA. There were only 100 women, as I mentioned, single center. I don't know how comparable it would be to our site, but their sensitivity and specificity for the Wells score and Geneva scores were not particularly outstanding. And in their patients who fit into the low category, so the low risk patients for the Geneva and Wells scores, still about 20% of those patients did ultimately have a PE despite being categorized as low risk by these scores. So that doesn't give me a lot of comfort in these scores. And just to give a visual, because I'm a picture person, I just wanted to put up the receiver operator curve, which these are curves that help compare the false positive rate to the true positive rate. And essentially, if you look at the far left, that helps you know what a good score is, where a good score would fall on this line. And so a good score is where that yellow curve is. And if you were along the diagonal line, it essentially means that your test is worthless. Your test cannot differentiate two binary outcomes better than chance. So that line is equivalent to chance. And then if you're further to the left on that curve, you're doing better. On the far right, this is what the receiver operating curve looks like for the Geneva and Wells scores in patients outside of pregnancy. So it's reasonable. It's not on the amazing side, but it's definitely between kind of good and excellent, and so they're reasonable scores to use. I just plotted the scores from this study on a graph. I couldn't actually figure out how to make a true ROC curve. I apologize with my computer skills, but you can see that those 2 points are probably somewhere in the good to heading towards not being able to discriminate from chance. So they're not in the excellent range, so not something I would be jumping to use immediately. And then there was another study that actually did a proper analysis of multiple risk stratification scores. And the one I want to point out is that the pink line of risk stratification scores that seems to be doing better than all the others, that is the Wells score when they did their analysis. So maybe some value, but I'm not 100% convinced. So who else has looked at this? Well, there was another study done in 2011, and this was a prospective study that looked just at the modified Wells score in pregnant and postpartum women, again, suspected of PE, who were already going for a CTPA. Again, only 100 women, and they only had a prevalence of 5% positive for PE, so pretty low rate of their actual outcome. And they showed good results for the Wells score. So they said that if you were greater than 6, so in the high risk category on the Wells score, that you had 100% sensitivity and 90% specificity, which sounds really good. If you were below 6, then you had a negative a predictive value of essentially 0. But again, with a low prevalence, that's going to affect that negative predictive value. It's a very small study, so I'm not 100% convinced, but maybe with more research, there might be some benefit to the Wells score down the road if we figure out how to adjust it, where to make our cutoffs, and if any changes need to be made to it. So ultimately, for risk stratification scores in pregnant patients, there's a paucity of research for these scores. None of them have been completely validated for use to show that they're useful or that they are safe. And the Wells score shows probably the most promise for the future, but I don't feel after I've done this that I'm quite there yet where I feel like this is a safe test to justify avoiding further testing and investigations. So what about the D-dimer? So as I mentioned, D-dimer levels rise through pregnancy. So multiple studies have shown that as you go through pregnancy, your D-dimer level increases. And by the time women are in the 3rd trimester, they're usually getting average levels of D-dimer in the 2,000, sometimes in the 3,000 range. So very positive D-dimers. And these are just, again, some visual images to show that as you go through pregnancy, the D-dimer level does climb significantly. So what about in the postpartum period? Postpartum, the D-dimer level does start to decrease as people come further out from their delivery, but in the first 6 weeks, it is still definitely in the elevated range, and so its utility is still a bit debated. By 6 weeks postpartum, so 42 days, the D-dimer has come back down to baseline levels, but as you remember, I did mention that the risk of PE can actually still go out to 12 weeks, that increased risk in these women. So this was a Canadian study done in 2010, and they wanted to see if a higher D-dimer level could rule out a DVT or venous thromboembolism in pregnancy. So they did it in a bit of a backwards way. They weren't doing this in a clinical setting, but what they did was they took blood from a bunch of women who had suspected DVT, who were postpartum or pregnant. These were all pregnant, I apologize. And they were looking for women who were suspected DVT, and then they compared their D-dimer tests in the women who had DVTs and didn't. And they used 5 different D-dimer assays, and then with those 5 different D-dimer assays, did a data analysis to plot several receiver-operator curves, and then from that decided where seemed like a safe cutoff to get the sensitivity and specificity that they wanted from these tests. So ultimately, they decided using 5 different D-dimer tests and about 250 patients that a D-dimer cutoff of about 1,500 in all of pregnancy might be reasonable. They didn't separate these patients by trimester, and this was never actually tested clinically to see if this value would be a safe cutoff value or a useful cutoff value, but this was kind of their idea of a starting point where it might be of utility. So who's actually looked at this in a clinical setting? Well, there was this study done just this year that was a prospective cohort study of pregnant and postpartum women with suspected pulmonary emboli. It's about 325 women in 11 hospitals in the United Kingdom. They tested 2 different D-dimer cutoffs. So they said that their second trimester cutoff was going to be 750, their third trimester cutoff was going to be 1,000, and they wanted to see if this had any benefit in separating out people who had PE and didn't have PE so that they could avoid imaging. Ultimately, their normal cutoff, using a normal cutoff of 500, had a sensitivity of 88% and a specificity of 9%. And when they did the higher cutoffs, they actually lost a lot of sensitivity and went down to 70%, gained some specificity up to 33%. But as we all know, the D-dimer is a test where you really want high sensitivity because we don't want to miss patients and not image them, so we want our sensitivity to be high, and we expect that our specificity might be a little bit lower, but that's the goal of this test. So then again, I decided to plot this, because I'm a picture person, on a ROC curve, and both of those points fall basically right along the line of chance. So if these are specificity and sensitivity values, they're not really going to help us differentiate who's got a PE and who doesn't, and where we should be imaging people. And so interestingly, I just wanted to bring up Dr. Klein's algorithm, the one that's presented to us in Rosen's and Tintinelli's, and he's suggesting cutoffs of 750 in the first trimester, 1,000 in the second, and 1,250 in the third trimester. And I looked and was unable to find any studies that validated these values or demonstrated that they were safe to use, and they're actually less conservative even than this study. So that doesn't really give me a lot of warm and fuzzies about using that algorithm at this point with the information that I was able to find. So ultimately for D-dimers, they're always elevated in your postpartum and pregnant patients. The normal cutoff doesn't really help decrease the number of people who are going for CTs and VQ scans, so probably not much utility there. And if a higher cutoff is useful, it has definitely not been demonstrated yet in a clinical study, and so it has not been validated for safety or utility. So where do we go from here? We now have 2 essentially not very helpful tools, so we are left with our imaging. I really want to focus on the VQ and CTPA because this is where I feel like we have most of our struggles deciding what to do with these patients in the department. So we're always concerned about the radiation dose. In a VQ scan, you actually get more radiation to the fetus than you do to mom. So that's the concern with a VQ scan. And there's more radiation to the fetus in a VQ than there would be with a CTPA. Whereas if you do a CTPA, you're giving a large dose of radiation to mom, in particular to breast tissue, which is currently actively changing breast tissue, so presumably higher risk of radiation damage. And you, with the CTPA, you get less risk to the fetus. Laura, did you have a? Yeah, absolutely. So I don't think it's quite half, but I didn't find the actual values. But yes, so with VQ, I was going to get to it later, but I'm happy to talk about, oh, not a problem, I'm happy to talk about it now. So there are things you can do with the VQ scan to further decrease these radiation doses. So one is that if you already have a chest x-ray, you can then do perfusion only because they can use the chest x-ray as their ventilation. And if you would like, you can also insert a Foley catheter and hydrate these patients through the procedure as well as after. And the idea with that is that you now have a radioactive isotope systemically injected into mom, and then when it gets excreted, it sits in the bladder right next to the uterus, and you now have an isotope right next to your fetus. So if you have a catheter in, as soon as they release this isotope into the urine for excretion, you get it immediately out and into a bag. And if you're hydrating, you help continue flushing that out of the system, hopefully faster. I didn't find anything that shows that there's different clinical outcomes with doing this, but I definitely think it's something that will make me feel better, and I will probably be doing from now on because I feel like the risk of doing it outweighs the harm of possibly hydrating them better. So there are things you can do with a VQ to further decrease that risk. And so what are the dangers of radiation? Why are we so scared of giving radiation to fetuses or moms? So with fetuses, there is a cutoff that they say is the maximum recommended fetal exposure through pregnancy, and that's 50 milligeigers. And as you can see, that's not even close to any of the exposure amounts that the fetus is getting during these tests. So we're still staying well in the considered kind of safe-ish range. The threshold for where teratogenic changes can occur is about 100, and even above that, at a dose of 250, only 0.1% chance of malformations in the baby. So we're definitely staying in a safe zone when we're doing these tests. So I would take away a little bit of that guilt that we feel when we order them. And then what does radiation actually do in different trimesters? In the first trimester, it's kind of an all or nothing effect. So if baby gets too much radiation, women tend to go on to have a miscarriage. If they receive a dose that's not kind of more dangerous, they tend to continue on with the pregnancy. Second trimester is a bit scarier. This is where baby's developing a lot. So there are risks of malformation and mental retardation if we go above those danger thresholds. And in the third trimester, malformations are not the concern, but it's really unknown what kind of an increased cancer risk the fetus might be put at, or the child eventually when they grow up. And then in terms of mom, I already discussed that breast tissue may be potentially very sensitive at this time as mom's body's undergoing a lot of changes. And with the CTPA, I put these scores into the X-ray risk website, which if you haven't used it, it's kind of a neat site to give patients information about what their risk of cancer may be as they undergo testing. But CTPA increases the risk by about 1 in 450, and VQ increases the risk of cancer by about 1 in 3,000. So nice to be able to give those numbers to patients if you need to. So what studies have looked at CTPAs versus VQ in terms of their diagnostic abilities? So there have been several studies that have demonstrated a similar thing, but I'll just go through one. So this study was done in 2009, and essentially they went through a bunch of CTPA and VQ scans in pregnant women and wanted to see how many were adequate for determining whether people had a PE or not. 35% of the CTPAs were inadequate to determine if a patient had a PE, which is much higher than in our normal population. Interestingly, only 2% of the VQ scans were inadequate. And so why would that be? I am definitely no radiologist, but the theories that they put out in the paper suggested that the hyperdynamic state in pregnancy, hemodilution, and interruption of contrast from non-opacified blood coming from the IVC may contribute to their inability to use CTPA as effectively in pregnancy as they would otherwise. So if we have, this is another study that looked at similar things, so how many non-diagnostic CTPAs you had and how many non-diagnostic VQs in pregnancy and postpartum. And this was about 300 women who were involved. And they found that 17% of their CTPAs were non-diagnostic, about 13% of their VQs were non-diagnostic, so about the same performance level. But when they did a subgroup analysis, it showed that if you had a normal chest x-ray, then only 5% of the VQ scans were non-diagnostic, while still 30% of the CTPAs were non-diagnostic. So in the group with a normal chest x-ray, your VQ scan is going to perform better than your CTPA, which is why we're seeing all those guidelines suggesting that. And then comparatively, in an abnormal chest x-ray, 16% of the CTPAs are still going to be non-diagnostic, which is not great, but 40% of the VQ scans are non-diagnostic. So your VQ becomes much less useful in the abnormal chest x-ray population. And so that's why I want to highlight this study, because a lot of the guidelines show that you should use your chest x-ray to decide between VQ and CTPA, and this is the reasoning behind that. So ultimate comparison between CTPA and VQ scans, there's advantages and disadvantages to both. So CTPAs are obviously accessible. We can get them on the weekends, we can get them in the night if we need to. There is less fetal radiation if that's your biggest concern. And it can also help establish alternative diagnoses if you're not quite sure that this is actually a PE. Disadvantages are that there's a higher maternal breast radiation, and there's also poorer quality CTPAs in the pregnant population, so you may want to use your chest x-ray to help guide whether that's the test you want to choose. In terms of VQ scans, there's lower maternal radiation, but there is higher fetal radiation. Of course, with all these tests, the radiation dose is still within the kind of safe threshold in pregnancy. Your VQ scans have fewer indeterminate scans if you have a normal chest x-ray, and you have other strategies where you can maybe further reduce the radiation. So as mentioned, things like perfusion-only scans or hydration and Foley catheters. Of course, there are disadvantages. Less accessible. We've all had to fight for a VQ at some point, so it can be difficult to get at odd hours, and there is poor diagnostic adequacy if you have an abnormal chest x-ray. So let's jump back to our patient. So we had Natalie come in. She's got pleuritic chest pain, a little bit tachycardic, a little bit tachypnic. What do you want to do with this patient? So I'm just going to take you through a show of hands. So who would like to do a risk stratification score? So any risk stratification score, who would like to calculate one of those? So we've got some tentative maybes. We might try it, but I think I may have convinced you otherwise. D-dimers. Who would like to send off a D-dimer? For interest's sake, maybe. I don't know that it's going to get me away from my VQ or CTPA. Who would like to do a VQ or CTPA? Yeah. So yeah, I would get a chest x-ray first. I'm glad you're all mentioning that. So I think that's exactly what I would do. I don't think that I would order a D-dimer at all in this patient. I might get blood work if I'm concerned about other things, but I don't think I would order that extra test. And I'm not comfortable that my risk stratification scores can actually tell me anything at this point, so I'm with you on that. So my take-home points are, for eclampsia, make sure you keep this on your differential and keep your differential really broad for your pregnant and postpartum women, or just generally women of childbearing age, because they may not tell you that they are postpartum. And if you do get an eclamptic patient, different seizure management, huge doses of magnesium. And then for pulmonary emboli, the risk is highest within 6 weeks postpartum, so that's your highest risk time, but that risk does increase as we move through the 3rd trimester, and it comes back to baseline at about 12 weeks postpartum. Don't think there's any role for risk stratification scores or D-dimers as far as I can tell from my lit review. And from an imaging point of view, CTPA and VQ, I would base my decision on discussion with mom about the risks and benefits of both, as well as on their chest x-ray, whether it's normal or abnormal. And I would probably put more weight on my chest x-ray than I would the discussion. I might include that in my discussion with mom. I did want to make a brief mention of Doppler ultrasounds for the legs. I think most things that I was reading suggest only doing this if patients are symptomatic from a DVT point of view. But the concern with doing Doppler imaging is that it's not always that accessible. It's not always faster. If you're someone who has the skill to do it at the bedside and you can quickly diagnose a DVT, I think that's great. But if we're waiting for 2 sets of imaging, I think the risk of waiting too long in a patient who could potentially have a PE and not treating is not quite there. But I didn't go digging too far into the Doppler ultrasound world. So I would like to thank Scott Anderson for helping me put together the presentation and giving me that really interesting case that we started with. And Dr. Stephanie Sibley is a doctor I worked with in Kingston last year, and she gave about a 10-minute presentation on D-dimers in pregnancy last year, and that was kind of what inspired me to put together this round today. So if anyone has any questions or wants to chat, I'd be happy to do that. Yep, Laura.
About the why don't we start with a leg ultrasound thing, is that because we're still going to need to get the imaging of the chest, because they're going to want to know a baseline view of what that view looks like, so that if you have worsening symptoms, you need to determine is this another PCD and have you failed therapy, for example. So you're not really going to save that patient imaging of their chest, even if you get a positive leg ultrasound. Yes, you can treatment getting sooner, but you're still going to need to go down that road.
Okay, that's a great point. I didn't read that, so thank you for adding that. Yep.
Chantal, has anybody quantified the risk related to breast regarding pregnancy?
So not that I saw, and a lot of the comments that say, this tissue is more at more risk than, a woman who's not pregnant, her breast tissue, it all seems to be theoretical from what I saw. I'm going to admit I didn't go digging on that tangent from a lit review point of view, so there might be something, but everywhere that I was reading it was all this is, a theoretical risk increase in pregnant women versus non-pregnant. So.
But even in the non-pregnant women, the radiologists are trying to discourage us from doing CPAs in those women too. So
yeah.
You can imagine that it's not a great thing.
Yeah, there was a specific number, like, it's 100, 451 is the theoretical risk of a CPA, but it's just more specifically related to breast cancer.
Well, that makes you wonder if in the near future we're not going to be able to get EQs at all, right? I suspect that's the way it's heading. Nuclear medicine's not going to be this in 5 years. Not for my opinion, but nobody has to.
I hope that's not the case, because I now am a bit more of a fan of VQs, so hopefully things don't go that way.
I must say, I tend to do a D-dimer sometimes on these people, and I just hope and keep my fingers crossed that we get a really low value.
Yeah, and so I guess you can kind of hope that I'm not sure that, I haven't found anything that says this cutoff is still reasonable. Presumably it makes sense that if you get an actually negative value like 300, it should be safe to use, but it hasn't been tested. So from sitting in a courtroom and justifying myself, I'm not sure I'm there, but I think you would obviously do a better job justifying yourself in court than I ever would. So it would for sure. Yeah. So I, again, didn't go digging this way, but I did find a lot of papers as I was going through that just the abstracts were saying that treatment is very safe and encouraging not shying away from treatment in pregnancy. So I don't know how high those risks are, but the literature that I was kind of quickly skimming through seemed to really encourage treatment. And all the guidelines definitely said that normal treatment was what they would recommend. So I don't know that the risk is that much increased in pregnancy. I think the risk of not treating is probably way worse ultimately. So. Oh, good call. There are flu shots being administered just outside. Yes, by Lou. So they'll be excellent. Yeah, so stop for your flu shot on the way out. Thank you, guys.
You're up.